Okay. The next one, you had a 51-year-old woman who comes to the GP because of fatigue and progressive pain and stiffness in her hands for 3 months. She used to play tennis, but she stopped a month ago because of difficulties holding the racket and her skin becoming very sensitive to sunlight. Her last menstrual period was a year ago. She has diabetes mellitus, which is controlled with insulin. She doesn't smoke or drink alcohol. Her vital signs are within normal limits, and the patient appears tanned. And the second and third metacarpopharyngeal joints of both hands are tender to palpate, and the range of motion is limited. Which of the following is the most appropriate next step in diagnosis? So she has progressive pain and stiffness in her hands for 3 months. She used to play tennis but stopped because she can't hold the racket. And her skin is becoming sensitive to sunlight. So it's thinning, it's becoming sensitive to sunlight. She's menopausal, she has diabetes, and her skin is tanned as well. Okay, so it doesn't sound like gout because gout wouldn't cause your skin to become sensitive to light. It wouldn't cause your skin to be tanned. And she doesn't smoke or drink alcohol. Alcohol would increase the risk of having gout attacks. It doesn't mention anything about her diet or anything about, a painful swollen joint, which you'd get with gout. So that rules that one out. Calcium concentration maybe because of this, the fact that she's menopausal and then she's having these, this bone ache, the ache in her, the metacarpopharyngeal joints, and they're tender as well. But then it doesn't explain the tanning of the skin, and it doesn't explain that it's been going on for the sensitive to sunlight, the skin becoming, very sensitive to sunlight. That wouldn't be explained by osteoporosis. Synovial fluid analysis doesn't make sense, and testing for rheumatoid factors wouldn't also make sense because, again, the sensitive to sunlight and the tanned skin aren't fitting with the picture. So that leaves us with iron studies and the fact that, she's got this tanned skin deposit, that could be deposition of iron in her skin. The fact that she's fatigued, that can happen with excess iron or, low iron. Either ways, you can get fatigue because of your iron being too high or too low. And then also the fact that her skin is becoming very sensitive to sunlight and tanned. We said that goes with iron, and the diabetes as well. Diabetes and hemochromatosis, they might have a link. So everything in the question points towards iron studies most out of all the other tests that you can see. So the patient's presentation includes fatigue, symmetric arthralgia that's affecting the metacarpopharyngeal joints, along with skin hyperpigmentation and diabetes, so bronze diabetes. That all suggests hemochromatosis. In premenopausal women, iron loss from menstruation can delay disease progression. So people who premenopausal, because they're women, it's harder to diagnose hemochromatosis with because they're already losing that iron monthly, but then the minute they hit menopause, it starts to show a lot more. So in a menopausal woman, as this patient, hemochromatosis will cause iron accumulation in multiple organs, and then you'll see the same symptoms that you've seen here. So the sensitive skin, the bone ache, the arthralgia, the joint ache, and then also the fatigue and everything. Iron studies in this patient will most likely show serum iron, serum ferritin, and transferrin saturation all increased. And for patients with confirmed iron overload, usually they do genetic testing for these genes, so C282Y and H63D mutations, to confirm the diagnosis of hereditary hemochromatosis. Okay, the next one was a 12-year-old girl who was brought to the emergency department 3 hours after the sudden onset of colicky abdominal pain and vomiting. She also has redness and swelling of the face and lips without pruritus. Okay, her symptoms began following a tooth extraction earlier this morning. She had a similar episode of facial swelling after a bicycle accident 1 year ago, which resolved within 48 hours without treatment. Her vital signs are within normal limits. Examination shows a non-tender facial edema, erythema of the oral mucosa, and an enlarged tongue. The abdomen is soft, but there's tenderness to palpation over the lower quadrants, and an abdominal ultrasound shows segmental thickening of the intestinal wall. Which of the following is the most likely cause of this patient's condition? So 12-year-old, she had a tooth extraction, so trauma, and then after that she started feeling, 3 hours later, she started having abdominal pain, vomiting, and she has redness, swelling of her face and lips, but without pruritus. Okay. So the fact that it's without pruritus, that kind of rules out, an allergic sort of reaction to something that she was given at the dentist's. And the fact that also she's getting abdominal pain and vomiting doesn't fit. But people that usually get, hereditary angioedema when their face puffs up after, trauma, dental tooth extraction or things like that, they wouldn't have pruritus, they just have the swelling, and they could have also abdominal pain and vomiting. So that fits with hereditary angioedema. And people with hereditary angioedema, they usually have C1 deficiency, so that's the complement inhibitor deficiencies. So complement inhibitor deficiency, or more specifically C1 inhibitor deficiency, complement 1, is the underlying cause of hereditary angioedema. A deficiency or dysfunction of C1 inhibitor results in elevated levels of bradykinin, which is a strong vasodilator. So then that's why she had the flushing and the facial swelling, and the tongue was swollen as well. It's characterized by recurrent episodes of swelling without itching, without urticaria, without a rash, without pruritus, and it primarily affects the skin and mucosa of the gastrointestinal and upper respiratory tract, which is why she was having, the vomiting, and then also the fact that her the vomiting and the colic abdominal pain, in this case gastrointestinal tract and upper respiratory tract. The most common triggers are stress and trauma, especially from dental procedures, and the episodes are usually self-limiting, and they resolve within 2 days to 4 days time. And this was the case in the patient's previous attack as well, the fact that she's had it before. Hereditary angioedema is autosomal dominant, but 25% of cases are spontaneous mutations. Okay, so that was that one. Then you have this 14-year-old girl who comes to the GP with her father for evaluation of short stature. She feels well overall, but is concerned because all of her friends are taller than her. Her birth weight was normal. Her father reports that he had a short stature during his teenage years. He's currently 177 centimeters tall, and the daughter's at the 2nd percentile for height and the 35th percentile for weight. Breast development is standard stage 2, pubic and axillary hair is absent, and X-ray of the left hand and wrist show bone age of 11 years. Which of the following is most appropriate next step in management? So this sounds like the same thing that happened with her father. That when he was younger, he had a short stature. Then he had, that the boost, the puberty growth spurt, and then after puberty, he just went to his normal height, 177 centimeters. So, and she's also in 2nd percentile and 35th percentile for weight, so she's not, below the normal completely. So, and even though it's 11 years, in people that have the thing where the fathers are short as well, and then they eventually catch up after they hit puberty, it's okay if their bone ages within 2 to 3 years of their own age, which in this case is within 3 years, so it's fine. So you just have to keep an eye on it and monitor it just to make sure she doesn't lag after she hits puberty as well. So constitutional delay of growth in puberty, it's a common normal variant of growth in which children have short stature, usually below the 3rd percentile during childhood, and delayed puberty. The affected individuals usually have a normal length at birth, but growth velocity decreases between 6 months and 3 years of age. The bone age is typically delayed by 2 to 4 years, so growth continues for a longer period of time. So in this case, her bone age was 11 and she's 14, so it's okay. However, after a growth spurt in late adolescence, patients usually, reach a normal adult height. While patients should be closely monitored to ensure that, their growth velocity doesn't decrease any further, you don't need to treat them or do more investigations for it. So just reassurance and follow-up for this patient. Especially because the dad had it, it makes sense that it's something that the child might go through as well. Okay. The next one, a 27-year-old man comes to the GP because of a 4-month history of recurrent episodes of headaches, palpitations, and sweating. He was adopted shortly after birth and doesn't know his biological parents. Okay, his pulse is 103 and his blood pressure is 160 over 105. His physical examination shows multiple soft yellow papules on the tip of his tongue. There's a 2-centimeter firm thyroid nodule. He has long and slender upper extremities, and his elbows and knees can be hyperextended. The most likely cause of this patient's condition is a mutation in which of the following genes? So this guy has a lot going on. So 27-year-old, 4-month history of recurrent episodes of headaches, palpitations, and sweating, and his high blood pressure. That all sounds like pheochromocytoma. And then multiple soft yellow papules on the tip of his tongue, 2 centimeter firm thyroid nodule, so his thyroid's involved, and he has long and slender upper extremities, sounds like Marfan's, and his elbows and knees can be hyperextended, also sounds like Marfan's. So all these together usually come with multiple endocrine, the multiple endocrine neoplastic syndromes, the men's, especially with men too, they have Marfan, they're associated with Marfan syndrome. And the gene that's usually affected in men too is the RET gene. Yeah, so multiple endocrine neoplasia type 2, you have MEN2A and you have MEN2B. It's because the functional mutation is of the RET proto-oncogene, so the RET encodes a receptor tyrosine kinase that plays a key role in cell growth, differentiation, and survival, and usually that's the gene that's affected in men too. And then usually they have medullary thyroid cancer, which develops in almost all patients, and you have pheochromocytoma. And you get that with both MEN2A and MEN2B. MEN2A, you have hyperparathyroidism as well, and MEN2B, you have Marfan syndrome, or Marfanoid body habitus, and mucosal neuromas. So in this case, it sounds very much like MEN2B, because he has the Marfan body habitus. Okay. The next one, you had a 45-year-old man who came to the emergency department because of hematuria and bilateral flank pain. He's passed urinary stones twice before and has a history of recurrent urinary tract infections. He reports no recent trauma. His father had a history of kidney failure and underwent a kidney transplant. His temperature is 38 degrees, pulse is 110, and blood pressure is 155/98. His abdominal examination shows palpable bilateral flank masses, and results of a complete blood count are within reference range. His serum creatinine is 2.9. Which of the following findings is most likely to be associated with this patient's condition? Okay, so 45-year-old has hematuria and bilateral flank pain. He's getting kidney stones. He has kidney stones in the past as well, so recurrent kidney stones, recurrent UTIs, no recent trauma, but his father had the same sort of thing. He had kidney failure, he had to have a kidney transplant. And in this case, he's probably going through a UTI again with a temperature of 38 degrees and a blood pressure of 155/98. He's got bilateral flank masses that are palpable. Okay, and results of a complete blood count are within reference range. His creatinine is 2.9. Which of the following is most likely to be associated with this patient's condition? So it sounds like, because it's a familial thing, it sounds like, and you can feel the bilateral masses, it sounds like polycystic kidney disease. And because of the different options that you're getting here. Vesicular reflux, they come when they're younger and they'd have like recurrent urinary tract infections. Colonic wall ulcerations doesn't make sense. Portal hypertension, can't see the relation. Osteolytic bone lesions, if you were suspecting multiple myeloma or something, but it doesn't fit with recurrent UTIs. And the fact that his dad needed a kidney transplant, if it was multiple myeloma, it would have been, bone marrow transplant. So that leaves us with cerebral sacular aneurysm, and patients with polycystic kidney disease, they have sort of a connective tissue disorder, so they're likely to develop aneurysms as well, including the cerebral sacular aneurysm. So cerebral sacular aneurysm can occur in 20% of patients with adult polycystic, the autosomal dominant polycystic kidney disease. And the other extrarenal manifestations, so you can get multiple hepatic cysts in 70% of cases. You can get hypertension, which this patient had as well. And you can get mitral valve prolapse, because again, they have this connective tissue disorder as well. So they can get mitral valve prolapse, they can get sacular aneurysms, hypertension, and multiple hepatic cysts. This patient's low-grade fever is likely due to another urinary tract infection.